The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today I'm going to do a podcast on the master drug. And why do I say that? Vasopressin, the more and more I study vasopressin, the more and more I read on it and see the different trials and see the different research being done, the application of vasopressin, I'm becoming more of a fan, and I believe that this truly is the master medication. There really isn't any side effects to giving vasopressin, and there are so many different applications to vasopressin. And so what inspired this podcast was I've been waiting for a study to be done for a few years, and the study is called the AVERT Shock Trial. It's done or has been being done at the University of Pennsylvania in Pennsylvania by a doctor named Carrie Sims. And so the trial again is AVERT Shock, arginine vasopressin during the early resuscitation of traumatic shock. Again, this is just a preliminary release. They show a final release this month. So I just wanted to get this out, just kind of talk about this. I think we'll do a follow-up podcast on this, but I also want to kind of talk about everything related to vasopressin, all the different applications, things that we're seeing, maybe some ideas that we can learn from as far as what does anesthesia use vasopressin for? How does that apply to our clinical practice in the HEMS industry or pre-hospital industry? So let's review vasopressin really quickly. We know vasopressin is called arginine vasopressin. We know it's used in our body by multiple systems, and it is really essential for just homeostasis regulation. Its sole purpose is going to be to maintain water absorption or reabsorption. And so it tells the kidneys, tells the body when to hold on to or get rid of water, essentially. We're going to talk about disease processes or presentations that alter that. We also know that vasopressin is very important to cardiovascular homeostasis. We know it's secreted by the anterior pituitary gland, but it's also very important for our actual mood states, our emotional status, and social behavior. So vasopressin is essential in so many different areas of our body to maintain normal regulation. As I said, its sole purpose is basically to prevent water loss from the body by reducing urine output. And so this helps the kidney reabsorb water. We also know that there are three main systems that regulate our blood pressure. And we're going to come back to a couple of these, but I just want to hit on these before we start talking about the different parts of the vasopressin podcast. The first is obviously our sympathetic nervous system. And our sympathetic nervous system is essential, gives us our beta 1, our beta 2, regulates our heart rate. So obviously that is something we all should know and understand. Number 2 is going to be our renin-angiotensin cycle. How does that regulate, or how important is that? Well, we know that's very, very important. And we know that providers, the number one prescribed blood pressure medicine out there is going to be an ACE inhibitor that blocks the conversion of ACE binding with angiotensin 1 that forms angiotensin 2. So we'll go through that process here in a few minutes. And then the last one is the arginine vasopressin system. Those three systems maintain our blood pressure. So we need to understand that medications that may cause a blunting of this, so imagine patients that are on ARB medications. ARB medications actually act on angiotensin 2. So it's an angiotensin 2 blocking agent, and we'll talk about that again. ACE inhibitors, again, block that ACE enzyme. So there's no conversion from angiotensin 1 to angiotensin 2. So we got two medications there that are solely affecting that part of that cycle. And then what about trauma patients? What about really any hemorrhaging patient? think about the vasopressin depletion. Actually, any stress hormone these patients don't have. And so how does vasopressin affect those patients? And again, that's the basis or the kind of the inspiration of this podcast was this trial. So let me give you some background on this trial. The purpose of the trial was patients, trauma patients specifically, who are transfused with multiple blood products to treat shock due to blood loss, frequently develop inappropriately low vasopressin levels. Vasopressin is a hormone necessary to maintain an adequate blood pressure, and low levels have been associated with a need for increased transfusions, vasopressors, and additional morbidity and mortality. Vasopressin is routinely used in the ICU for sepsis, we know that. And so the study, the AVERT shock study, will investigate the potential benefit of early vasopressin supplementation during the resuscitation of trauma patients and how that applies to their overall survival. They're going to use a marker called copeptin as a vasopressin biomarker. So what they're going to do is trauma patients who receive 6 or more units of blood products within 12 hours of arrival will be randomized to receive a vasopressin bolus plus an infusion or the placebo, which will be normal saline. They're going to track these patients for 5 days, and they'll document, obviously, their demographic data along with their findings. So a little about this study is Dr. Carrie Sims did a podcast. I don't remember where the podcast was, but she tells the story of how she got the idea to do this study. And she's a 4th or 5th year resident. And forgive me, I might be a little off there, but it's been a while since I've listened to that. And she had a patient that was multi-systems trauma, massive hemorrhage, had multiple units of blood products administered. And he just wasn't responding. They had multiple vasopressors on. They had been given volume. They had blood transfusing. The guy wasn't responding. The guy was on death's door. And so she just hypothesized, I wonder how he would do with some vasopressin. So she started a vasopressin drip. And lo and behold, the patient responded really well. She was able to finally titrate those other pressors off. And by the next morning, he was actually normal tensive. When she brought her treatment to the attending that's kind of over the residence, he wasn't really a big fan of what she did. I'll just leave it at that. But he challenged her to make sure that she has the evidence before she does something. And so that's what inspired her to do this trial. Again, the trial is done. All the data is being kind of extrapolated at this point. But let's kind of go through the different arms. So number 1 arm is vasopressin will be given as an initial bolus of 40 units. So again, that's the 10th of a cardiac dose, followed by an infusion rate between 0 to 0.4 units per minute. So the randomized arm is going to get the bolus of 4 units. They're going to get the drip at 0.04 units per minute. And then the placebo will get the normal saline, which is a 10 cc bolus, infusion of 0.1 mils per minute that will be titrated. In both of these arms, they're going to titrate blood pressure to a MAP of 65. Why a MAP of 65? Well, remember, a MAP of 65 is that golden number where renal perfusion either stops or continues. And so we got to maintain renal perfusion. We got to be maintaining that so we have a peeing patient, right? A peeing patient is a good patient. Kind of talk a little bit more about this. One of the things we have to understand is one of the number one secondary complications to trauma resuscitation, or once we get in the pre-hospital setting our patients to the trauma center, is our patients die oftentimes from these secondary issues. Obviously, inflammatory response, DIC. But one of the big silent killers was clinician-induced. And I'm not blaming pre-hospitally, I'm talking overall. We've learned that volume resuscitation with normal saline is bad. And so that's where we've employed the hypotensive approach, right? Permissive hypotension, I should say, where we try to maintain that MAP of 65, and that's it. Now, again, that's in a non-head injury patient. If we have a traumatic brain injury, we have to, again, kind of go in the middle there, and we've got to maintain a cerebral perfusion pressure of 90. So that kind of alters things. But we know that limiting volume, limiting normal saline is essential. And we have really seen a huge increase in aircrafts. I'm reading more and more that ground ambulances are carrying packed red blood cells. I actually just read the other day a ground service, and I don't remember where it was, they're actually carrying whole blood. So we've learned that abdominal compartment syndrome is a huge, huge killer. 70% mortality rate in these trauma patients if they get too much volume. And so that's actually completely gone away, or almost completely gone away. I mean, it's not as prevalent. It's not seen very much because we've done a really good job at limiting our volume and improving volume resuscitation with packed red blood cells, FFP, etc. We know, though, the hormone arginine vasopressin in particular may prove to be useful and a useful adjunct in resuscitation. We know it's secreted by the posterior pituitary. It's essential for maintaining vasomotor tone during hemorrhage, and low levels are associated with development of catecholamine-resistant hypotension and profound venodilation. So we have to understand that vasopressin is a powerful, powerful hormone. Low levels are not good. We see that in sepsis as well. So this study, what were the inclusion criteria? Again, trauma patients between the age of 18 and 65, so there was no pediatrics in this trial, who received 6 or more units of blood products. Again, blood products overall. Doesn't have to be packed red blood cells. So if you're given 3 units of packed red blood cells and 3 units of FFP, there you go. Exclusion. Traumatic brain injury was an exclusion. Active coronary syndrome, active MI, known renal failure or renal dialysis, patients that were pregnant, anybody less than 18, anybody that opted out, right? They can wear a bracelet, so obviously they had to announce this study. So any participants that opted out, or any patients under jurisdiction of the Department of Corrections. So as I said, the data is not out yet. The data is showing some pretty strong favor, which is really, really cool. So let's continue with our vasopressin overview and just talk about maybe some altered states, how vasopressin can cause some diseases. And we did this specifically, we kind of reviewed this in the podcast I did with my wife, where we did the endocrine nightmare. But let's just kind of review this. I think these are disease processes, endocrine emergencies are nobody's favorite. And so the first one is going to be the SIADH. And remember, SIADH is a syndrome of inappropriate antidiuretic hormones. So in this sense, what we have is we actually have an over secretion of ADH. And it's not so much your body secreting this or your pituitary secreting too much. It's actually getting tricked, and it's getting tricked by, pneumonias, viral or bacterial. It could be from like a carcinoma of the lung. Could be trauma, could be tumors, it could be meningitis, CVAs, things like that. But it causes a mimicker that tells the body to release this ADH. Well, what happens when we release ADH? Well, when we release ADH, if you think about antidiuretic hormone, that's what vasopressin is, our body holds on to all the water. So in SIADH, what happens is we hold on to volume and we start drowning in our own fluid. So how do we, number one, identify that? Let's look at some labs. Number one, your serum Oz. Remember that norm is 275 to 295. And what is it going to be in this case? Well, your serum Oz is going to be very, very low. Remember, a low serum Oz means that you are more cellularly hydrated. And so a lower number means you have more volume in your cells. You're going to have a dilutional state. These patients are going to show no clinical signs as far as edema. You would think that they would be holding on to all this volume, that they would be edematous, and they're not. They won't show that. The key, though, is they're going to have a dilutional hyponatremia, and so that's going to mimic CVA symptoms potentially. Always remember that could cause cerebral edema, and most often kind of that number of dilution is going to be less than 120. You could see seizure activity as well. So how do we treat this? Well, we treat the underlying cause, right? Number one, we try to figure out, do they have any pneumonia? Do they have any, cancer, any tumor, any trauma? We have to fix that. Number one, we have to give fluid restriction. We're not going to be giving them volume and volume resuscitate. And I think that's very common in really any presentation. We always want to start some fluids. We do not want to do that in this case. Number two, we want to look at labs closely. If you are in a dilutional state, you only want to raise that sodium at 0.5 milliequivalents per liter an hour. So very, very slow rise. And really the rule for raising sodium is if you know the sodium dropped quickly, you can raise it a little bit quicker. If the sodium has dropped slowly, you need to raise it slowly. Now, obviously, we don't know how quickly it's dropped, and I think it's always safe to always go slow. We don't want to cause the phenomenon of osmotic demyelination of the brain. That's a fatal secondary effect to raising sodium too fast. We want to give this patient Lasix, right? Optimize that urine output, get rid of that volume, and that's going to be 1 milligram per kilo. And then your hypertonic solution, as far as treating this low sodium state, this dilutional sodium state, is going to be 1 to 2 mils per kilo per hour. Remember, labs are based on a solute versus volume. And if we kind of use the analogy, if you have a bottle of water, right, 500 ml bottle of water, and you dump maybe a third of that out, you add a couple tablespoons of salt in there. That's maybe the proper concentration, right? That's a normal sodium level. Well, if we take that bottle, we dump everything into a larger container, and we add another 500 mils to that, now we have the same amount of solute, we have the same amount of salt, but we have a larger amount of volume in comparison. And so in that case, we have a dilutional concentration, and that's what your labs are showing. And it'll happen just the opposite. You're going to see in a dehydrated state, your sodium is going to be very high, your chloride is going to be very high, your H&H will be high. Well, that's a dilutional or a non-dilutional state. So that's a concentrated state based on now we have the same amount of solute, but we've gotten rid of a big chunk of water. And so now we have more solute to solution. So that's how our labs work. So SIADH, again, got to fix the underlying issue or try to identify why they're in this state. Fluid restriction, 3% normal saline, 1 to 2 mils per kilo per hour. We got to give Lasix at 1 milligram per kilo, obviously Foley catheter, and then raise that sodium very, very slowly. What about our next alteration based on vasopressin or antidiuretic hormone? And that is going to be diabetes insipidus. Why is it called diabetes insipidus? Diabetes insipidus is because diabetes means losing water, right? Shedding water. And so in this situation, what we have is we have a low level of antidiuretic hormone. These patients are often going to present secondary to head injuries, maybe infection, meningitis, could be tumors as well. Could be drug-induced. Some drugs to kind of look at would be dilantin or lithium. And so what's the main presentation? Well, these patients are going to be hypovolemic, and they're going to be really, really low on their volume. They're going to be in hypovolemic shock, and they're actually going to have electrolyte imbalances possibly. So lab findings, you're going to have a high sodium. You're going to have a high serum Oz. Again, remember serum Oz, the higher the number, 295 is the high end of normal. If it's above that, that means you have a dry cell. Water has left the cell. You have increased urine output. These patients can have loss of volume of 6 liters a day. And then your urine-specific gravity is going to be low as well. So what's the treatment? Well, again, the treatment is you got to identify the issue. A lot of times where I've seen these in case studies and transports is secondary to head injury patients where you have a big jump in ICP for whatever reason, and that has kind of triggered this whole response. So our treatment, number one, is look for any electrolyte abnormalities. Make sure you don't have any issues cardiac-wise. Make sure that you don't have any problems that you have to address right now. aggressive fluid replacement. Got to replace the vasopressin. And so the standard treatment nowadays is called desmopressin, which is called DDAVP, and that's a synthetic form of vasopressin. Works really, really well. Got to monitor that urine-specific gravity, and again, monitor the patient for any cardiac-related abnormalities based on those high labs. So those are two examples of endocrine emergencies related to vasopressin that we have to, number one, know how to identify, number two, know how to treat. What else can we kind of look at with vasopressin? As I said, blood pressure control is essential, and we have those three different systems with our sympathetic, number one, our angiotensin renin, number two, and our arginine vasopressin, number three. And this is where I think we can really learn a lot from anesthesia. And I'm currently doing a study right now where I'm looking at kind of all things related to mechanical ventilation and the ongoing sedation. I'm trying to extrapolate a lot of different data from these charts that I'm reading. And one of the hypotheses that I have is, we have an incidence, and it's really a low incidence based on the kind of the data that they're pulling right now. After talking to Dr. Dan Davis, it's about a 1%, so it's not a huge amount, but we have about 1% of patients that will have post-RSI cardiac arrest. And so what I want to kind of identify, despite giving ketamine or etomidate, the data is showing that it doesn't matter what medication you're using. We think that ketamine was kind of the save-all, that give that in every patient that had a low perfusion state, and they're going to do better in those cases where we're inducting them for the rapid sequence intubation. And we're finding that that's not the case, that these are the sickest of sick patients. We've kind of instructed all of our providers to go with ketamine over etomidate, and we're still having patients arrest. So it's not the medication, it's potentially other issues. I think one of it is I don't think we resuscitate our patients well enough prior to RSI. I think we rush in and move too fast. That's a big podcast that we can talk about on a next next topic. But I think overall what we have to understand is that we have other potential kind of silent killers in the background. One of those is, do they take medications that block that renin cycle? So there's two types of medications. And this is a common practice, a common understanding in anesthesia, right? We're talking about these guys in anesthesia, these anesthesiologists are doing this, or CRNAs are doing this, and they understand this. And you have a phenomenon where you have refractory hypotension during general anesthesia, rapid sequence intubation, that's refractory to push dose pressors that are beta in nature, so epi, things like that. So what do? They give vasopressin, and that's one of their pre-op identifications, that if these patients are on medications called ARB medications, so ARB medications are medications that are angiotensin II blocking agents, or if they're on ACE inhibitor medications, they automatically give a push dose pressor dose of 2 units for every single one of these cases, absolutely every one of them, just because of the high incidence of refractory hypotension during these procedures. So this is something I kind of brought up last year to Dr. Dan Davis. When we look at kind of, I try to keep Air Methods out of FlightBridgeED, but being PRN now and being part of the clinical team at the corporate level, that's something that we're always looking at. That's something I kind of respected, that a lot of the places around the United States had started using push dose pressors, and there's really not a lot of data. There's really no pre-hospital data, and anesthesiology hasn't done a good job extrapolating any data as far as can that be utilized in our environment. So I think, a lot of places have started utilizing push dose pressors, and Air Methods has kind of been more cautious, and I think that you have to respect that. And they're about to kind of pull the trigger on that and start doing push dose pressors in a couple different manners. But I had brought this up. I'm like, how does this apply to us? If anesthesia already knows this, we do have a big subset of patients. As I said, ACE inhibitor medications are the number one prescribed blood pressure medication for any new onset hypertension. How many people do you think that we have out there that have that medication as a blood pressure med? I mean, we have a lot of people that are in their late 20s and 30s that are hypertensive that take medications on a daily basis. So think about how that applies. And so that's where I brought this up. And I'm like, why don't we go with vasopressin? Vasopressin is a medication that we know in sepsis, for example, there's never a reason not to give it. It's been proven that in 85% of refractory hypotensive patients, despite Levophed being established and administered, volume resuscitation, that patients are still vasopressin depleted. You start vasopressin, if the blood pressure responds, you know that they were vasopressin depleted. If it doesn't respond, you know that they weren't. But there's no side effects to vasopressin. That's the thing. So why not try that? Why not establish a protocol utilizing vasopressin at 2 units, 4 units? You don't have to go above that. We kind of were talking about 4 units initially, but anesthesia uses 2. So use a tiny dose and ask these questions. Get a good history. Try to identify. If we don't know because there's no side effects to vasopressin, maybe that should just be our blanket push-dose pressor instead of epi, right? There's problems with epi. One of the problems with epi is that, push-dose pressor epi really reduces cerebral perfusion. So we got to always think about what that does to our traumatic brain injury patients. Post-cardiac arrest patients, they've already identified and understood this for quite some time, that epi, we may get pulses back, return to spontaneous circulation, but do we have any good cerebral perfusion now because we've given them, 6 rounds of epi? So this is just something to consider, something to bring to your medical director. I'm going to really start pushing this, I think. I've had some great discussions with Dr. Dan Davis. And, I think this is definitely something we could trial in a small area and see if there's any correlation. And what I'm hoping with the study that I'm doing, that I can correlate if we see after RSI a drop in blood pressure or, God forbid, an arrest situation. Did they have medications listed, number one? Were there any ARB medications or angiotensin blocking medications, ACE inhibitors? So how does that work? How does that system work? Remember, if we're talking about ACE inhibitor medications, we're specifically talking about blocking the ACE enzyme. And we know that ACE enzyme is that converting enzyme that's found in the lungs, and it binds with angiotensin 1, which converts to angiotensin 2. And angiotensin 2 is the big daddy. And this is the molecule or the enzyme that increases sympathetic activity. It is utilized in the kidneys for reabsorption of sodium and chloride, potassium, water retention, directly affects adrenal gland and the adrenal cortex overall, has a direct effect on arterial vasoconstriction and blood pressure, and also affects antidiuretic hormone or secretion of antidiuretic hormone. So you could see that an ARB medication, if you have an ARB medication on board, that blockade at the angiotensin 2 point is very, very powerful. So can these patients respond if they're already hemodynamically unstable, if you have a massive hemorrhage situation? They're on an ARB medication. We already saw from this trial that trial showed that these patients are vasopressin depleted. So that's 2 out of the 3 systems that our body is utilizing for normal homeostasis to maintain blood pressure that is now gone. So I just want you to consider some of these things. I'll put a like 3 or 4 studies in the show notes. You can take a look at this stuff. I think this is very, very intriguing, and I think it's something that we really should be looking at a little bit more close. Take this stuff to your medical director. I think that, again, the vasopressin as a push-dose pressor is going to be a great thing. I think the only thing we have to look at now is, can we get the cost down? Maybe these drug companies start seeing the use, or somehow we can affect that. I don't know how we can do that, but got to get the cost down for people to want to utilize this. And I think that's unfortunate when you see a medication so powerful like that. So that's all I have for this podcast. Again, I will do a recap podcast when all the data is kind of extrapolated and released. Remember, this is the AVERT shock trial, arginine vasopressin during the early resuscitation of traumatic shock. 2 different arms. Arm number 1 is that 4 units, followed by a 0.04 unit per minute infusion for 48 hours to maintain a MAP of 65. And then the placebo arm is going to be that normal saline at 10 cc's with a drip at 0.1 mils per minute to maintain a MAP of 65 as well. So if you have any questions on this, please don't hesitate to email me. I will put all of these studies in the show notes, as I said. And until next time, I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.